exposure, or as an autoimmune condition, one may see distal RTA.
And is this more of a sort of a proximal or a distal RTA that you will see in children?
More often.
So it's which form is more common?
Distal RTA is
Distal RTA is more common, and distal RTA, although in that scenario, you will have a issue in terms of having a more severe disease, but often the disease may not be very severe in the initial phase. So if you do a right diagnosis at the right time, you may be able to identify it, and that can really have a good beneficial effect in terms of the RTA. So we'll now talk a bit about the various aspects of RTA pathophysiology and in terms of etiology, and we will move forward from there. So over to you, Dhwani.
Thank you, sir. So once we have established that we are dealing with a renal tubular acidosis, so the necessary components are metabolic acidosis, which is normal anion gap, of renal etiology, of renal tubular etiology. So your renal function test should be normal. We need to know whether it is, what type of RTA is it, to know what management needs to be given. The most common one, as sir has already said, is type 1 or distal RTA. It could be either congenital or acquired forms. Congenital or the genetic forms of distal RTA could be autosomal dominant or autosomal recessive mutation, and acquired could be because of structural kidney disease, obstructive uropathy, secondary to autoimmune condition, and drug-induced distal RTA. The primary pathology here is defective acidification of urine, and therefore there is alkaline urine, more severe metabolic acidosis. It is an isolated condition, meaning that no other molecules or ions are lost as a result of distal RTA, and it is associated with nephrocalcinosis or urinary stones because there is no citrate urea happening in distal RTA. Next is type 2 or proximal RTA. Again, this could be genetic or acquired. The genetic forms of proximal RTA could be either an isolated problem in the sodium bicarbonate exchanger or a generalized tubular dysfunction result, as may be seen with cystinosis, tyrosinemia, GSD, and galactosemia. Acquired causes of proximal RTA include drug or toxin-mediated injury, as may be seen with acetazolamide overdose or heavy metal poisoning. Type 4 or hyper, these conditions have the primary pathology here is excessive bicarbonate loss, and as we already know, it is a self-limiting condition. So the urine stays acidic as the distal acidification process is intact in this condition. It is self-limited, and as we've already seen, generalized tubular damage will cause Fanconi syndrome. No calcification is seen in proximal RTA because of citrate urea that accompanies. Type 4 or hyperkalemic RTA is because of voltage gate defects or RAS defects. It presents with a milder tubular acidosis with hyperkalemia and low sodium. So we've already seen the pathophysiology of distal RTA. Let me quickly revise it for you. So in the distal convoluted tubule, you have the proton potassium ATPase and proton ATPase channels. These channels are responsible for active transport of proton into the tubular lumen. Transfer of proton into the urine is responsible for acidification. Defect in these channels will lead to reduced acidification of urine. Moreover, there is another pathology, which is the back diffusion of proton because of the high gradient, which is again responsible for reduced acidification of urine. So here the urine is alkaline, and since the proton diffuses back, there is low concentration of ammonium ion. All kinds of RTA will have hypercalciuria, but in the absence of citrate urea and distal RTA, you will see nephrocalcinosis and urinary stones. Interesting is potassium homeostasis in distal RTA. So as we've already seen that potassium and proton have an antagonistic action. In RTA, because you cannot exchange sodium for proton, you will end up losing more potassium in urine to exchange for sodium. Moreover, these children also have an occult volume deficit, which results in RAS activation and exacerbation of this hypokalemia. You will try to conserve more sodium in this volume depleted state and end up losing more potassium. So there is reduced proton excretion in distal RTA. And because of RAS activation, you end up losing more potassium, resulting in hypokalemia. So this hypokalemia in distal RTA is often present at outset and maybe the pathognomic thing that will help you in clinching diagnosis. Interestingly, with soda bicarb supplementation, there is resolution of acidosis and improvement in hypokalemia. SLC4A1 defect is an autosomal dominant form of distal RTA, which is due to defect in the anion transporter, anion exchanger, that is the chloride bicarbonate exchanger molecule channel. It results in mild acidosis, has a later presentation, is associated with nephrocalcinosis. And since this channel is also present in the RBCs, it is defect in SLC4A1 results in spherocytosis. The more dangerous one or the more severe one is the ATP6B1B1 defect. Here the defect is in the proton ATPase channel. And as we've seen with the classical pathophysiology, so there is proton secretion defect. These children present with early onset distal RTA, more severe clinical manifestation, and they have associated sensory neural hearing loss. Obstructive uropathies are funny in the way that they may present with picture like distal RTA or type 4 hyperkalemic RTA. These usually have classical polyuria and a milder acidosis that may be seen. Drugs that cause distal RTA commonly are amphotericin B. Now, the major mechanism of causation of distal RTA with amphotericin B is the tubular injury, which results in creation of ion permeable pores, which cause more back diffusion of proton back into circulation. Next is topiramate, which is an anti-epileptic drug. Here the problem is inhibition of carbonic anhydrase, which results in reduced H plus secretion. Lithium again causes cellular injury like amphotericin B and more back diffusion of proton. Autoimmune cause of distal RTA should especially be considered in someone who's presenting at an older age with features of distal RTA, especially around adolescence. Common autoimmune conditions that may be associated with distal RTA are SLE and Sjogren syndrome. The pathology here is presence of carbonic anhydrase antibodies, and diagnosis will be established by the classical features of Sjogren and SLE that you may see in the patient, and ANA profile will guide towards the final diagnosis. Moving on to proximal RTA. Now, the primary pathology in proximal RTA, as we all know, is bicarbonate uria. This could either be an isolated problem wherein the sodium bicarbonate channel is affected, or a diffuse or proximal tubular injury, which will result in glucose uria, phosphate uria, and amino acid uria along with your bicarbonate uria. As we've already seen that the threshold beyond which there is a threshold beyond which bicarbonate will not be filtered. So once your bicarbonate falls to 12 to 15 millimoles per liter, beyond this value, your bicarbonate will not fall and your acidosis will be self-limiting in proximal RTA. Since the distal acidification is intact, your urine pH will be less than 5.10. This is what differentiates proximal RTA from distal RTA. This is an interesting condition of proton ATPase maturation where it is delayed, that is delayed maturation. It is a transient self-limiting form of RTA. Usually, children present in the infantile age group and with maturation, they improve by childhood period. They respond very well to bicarbonate therapy. Now, like the SLC4A1 defect that we saw in distal RTA, we have the SLC4A4 defect in the autosomal recessive kind of proximal RTA. Here, the problem is an isolated sodium bicarbonate channel. Since it is isolated, you will not see glucose uria, amino acid uria, and phosphate uria. The manifestations are early onset proximal RTA like picture, and the children may also have cataract, band keratopathy, and enamel hypoplasia in this condition. Fanconi syndrome is a diffuse proximal tubular injury wherein you're losing everything. And the common conditions associated with Fanconi syndrome are Dent syndrome, cystinosis, tyrosinemia, Wilson, Gault, hereditary fructose intolerance, Loeys syndrome. Proximal tubular dysfunction due to drugs, again, if you think about it, it will cause a Fanconi-like syndrome because it will cause cellular damage in the proximal tubular cells. Commonly implicated drugs are the aminoglycoside, your gentamicin, tobramycin group of drugs, anti-cancer drugs like ifosfamide, cisplatin, or heavy metal poisoning like lead, mercury, and cadmium. Hyperkalemic or type 4 RTA is unique in that there is actually no renal injury. It is a defect in the RAS axis that is happening here. The primary problem here is a reduced sodium load at the distal convoluted tubule, either because of extremely low sodium diet or because of problem in the RAS axis. Now we know that in the distal tubule, sodium is exchanged for potassium and proton. So when the sodium delivery to the distal tubule is less, you will lose less potassium in urine, you will lose less proton in urine. So you will have hyperkalemia and metabolic acidosis. And as we all know that potassium and proton have antagonistic function. When the body is faced with losing both of these, it will prefer losing potassium over proton, as hyperkalemia has more acute lethal effects in comparison to metabolic acidosis. So although type 4 RTA has hyperkalemia, it will not be really very severe because it will ultimately be lost. And as potassium and proton are competing, potassium is lost more, there will be less NH4 plus in the urine. So there is low sodium load due to RAS defects, hyperkalemia and acidosis, and low ammonia in urine in type 4 hyperkalemic RTA. As a result, urine pH is greater than 5.3 here. Now, the common conditions associated with type 4 RTA are hyporenism that one may see, problems in the ACE inhibitor or axis, so ACE inhibitors and angiotensin receptor blockers, problems in the mineralocorticoid production, so adrenocortical defect or drugs that may cause that may affect the mineralocorticoid synthesis, aldosterone synthesis, that is defect in the aldosterone synthase enzyme, or a blockade at the level of mineralocorticoid receptor or ENaC channels, which may be either acquired or congenital, like pseudohypoaldosteronism, the autosomal dominant and autosomal recessive forms. Common drugs affecting the aldosterone axis may also result in type 4 or hyperkalemic RTA. Common drugs that may cause are beta blockers, NSAIDs, and cyclosporin, which cause hyporenism. Angiotensin receptor blockers, which basically act on the angiotensin 2 receptors. ACE inhibitors, which prevent conversion of angiotensin 1 to angiotensin 2. Heparin, which blocks the mineralocorticoid synthesis in the adrenal gland. The spironolactone mineralocorticoid receptor antagonist, and amiloride, which acts on the ENaC channel. Thank you.
Thanks, Vani, for this wonderful discussion and making things clear in terms of etiology. So, as you clearly said that more commonly we are seeing distal RTA, although proximal RTA is more varied in terms of etiology. When you talk about many of these disorders, like genetic disorders like galactosemia, fructose intolerance, many of them may have RTA as a combination. So you have to monitor them in that regards and setting. So now what we'll discuss is how do we really assess a child with RTA? The key question is it really RTA? If it's RTA, what type is it? And finally, what's the underlying cause? So as I said, RTA has a wide mode of presentation. Anybody who is not gaining weight, especially and height, so it's a nutritional pattern growth failure, refractory rickets with a low or normal phosphorus, renal calcification with normal serum calcium, periodic paralysis with hypokalemia, polyuria, which is unexplained etiology, and acidotic breathing, we should always think of RTA. Now, of course, growth failure is because of the direct effect of acidosis, as is rickets. The problem of calcification is because of hypercalciuria, specifically in the setting of a distal RTA. Periodic paralysis is more common, Vibha, in which condition? Distal or proximal? Distal RTA, because there the hypokalemia is more severe. And polyuria is largely because of, why do you have? Hypokalemia. So because of hypokalemia, you have nephrogenic DI that causes polyuria and acidotic breathing as part of the acidosis. So when you say renal tubular acidosis, the term is very evident. As I said, diabetic ketoacidosis, you say hyperglycemia, ketosis and acidosis. So this should be renal tubular, which means non-glomerular, and acidosis. So what you need to have is there is metabolic acidosis with a base excess, of course, is the best marker of metabolic acidosis. Along with that, you need to have a normal anion gap and an ammonium secretion, which is defective with a normal creatinine. That's a basic fundamental principle as far as RTA diagnosis is concerned. One of the cornerstones of diagnosing RTA is the anion gap. So anion gap is the difference between unmeasured negative ion versus unmeasured positive ion. But when you talk about in the measured sense, you can say it's the difference between the measured positive ion, which is sodium, versus the unmeasured ion like chloride and bicarbonate. So it's basically sodium minus chloride minus bicarbonate. The usual level is around 10 to 12. If you have accumulation of organic acids like ketones, like lactic acid, like organic acids, you will clearly have a elevated or an increased anion gap. That is very, very common in those metabolic scenarios. However, if the cause of acidosis is predominantly either a bicarbonate loss or a proton gain, you will have a normal anion gap metabolic acidosis. So there are very few differentials of a normal anion gap metabolic acidosis. One, of course, is renal tubular acidosis. The second is gastroenteritis. Third is ureterosigmoidostomy. And fourth is the use of acetazolamide. So this is like a very, very limited differential. So anion gap is a very, very important investigation to start off whether you're dealing with RTA or not. Now, once you have got an anion gap which is normal in a child who has metabolic acidosis with a normal renal function, I said there are two major causes. One is renal and the other is renal in the sense of renal tubular versus a gastrointestinal loss. So how do you differentiate the two? For that, you have to look at the acidification of the urine. Now, how do you assess acidification? We have discussed that it's the ammonia which actually goes along with protons. So ammonium production is a good marker. So what you're looking at is to detect NH4 plus in the urine. Now, how do you detect NH4 plus? Of course, this cannot be done in an easy way. You have to use indirect way. So one method is urinary anion gap. Again, the same thing, difference between unmeasured negative versus measured negative, or if you say sodium plus potassium minus chloride, that's what really means is the urinary anion gap. Now, if your ammonium is high, what will happen to the urinary anion gap? It will be negative because you're not measuring it, it will become negative, while if it's defective, it will be positive. So very clearly in conditions like diarrhea, you will have increased ammonium production. The urinary anion gap will become negative and you can really identify that. While whether you have a distal or a proximal RTA, the ammonium production is impaired. So your sodium and potassium will be more than the chloride. And clearly in this scenario, you will have a positive anion gap. So this anion gap in the urine is a good test to go in terms of identifying. There's another very interesting term of urinary osmolal gap. Now, when you say urinary osmolal gap, you are measuring the difference between the measured urinary osmolality versus the calculated urinary osmolality. So you basically calculate the same way. You multiply by sodium by 2, 1 by 2.5 and glucose by 18. If you just want to use sodium, what formula will you use for urinary osmolality? Urinary sodium to urinary osmolality. 4 times urinary sodium is usually the osmolality. So if you find that the measured osmolality is much more than the calculated osmolality, it means there is some new osmol which has been produced, and most common this is ammonium. So normally, if you have an increased ammonium production, this osmolar gap will go up. However, a caveat is that if you have a urease producing infection, you will of course have more ammonia coming in, which may be falsely giving you a negative scenario in that regards. So in GI losses, what you find is that your osmolar gap in that scenario will be increased because you're producing more ammonium. It will be more than 400, while in RTA, this is impaired and your osmolar gap will be less. So both urinary anion gap and osmolar gap are two tests which help you distinguish between these two conditions. So we have a 2-month-old boy with failure to thrive and diarrhea. pH is 7.16. There is metabolic acidosis. Base excess is -16. So Dhwani, in this scenario, anion gap is 12. How will you differentiate whether this is GI versus a renal tubular loss? So normal anion gap, metabolic acidosis. So you will check for the urinary anion gap. These are the values. What do you think now? So clearly your chloride is much more compared to the sodium and potassium, which means that you have some other positive form which you have not measured, which is ammonium. So this is more likely to be a GI loss. 12-month-old girl with failure to thrive, Alapan, pH is 7.12. There is metabolic acidosis that we are seeing. In this scenario, you are seeing this is the sodium, potassium, and chloride. What do you think here? $144. So 144 minus 12 minus 110. So it's definitely on the higher side. So do you think this is RTA? You have to start thinking of something else. I've seen many patients who are labeled as RTA, but the anion gap was not measured and they actually turn out to be organic acidemia. So anion gap clearly in this case is high. We have to think of some form of a organic acidemia in this setting. 5-year-old girl with rickets and polyuria, Vibha, weight is very less, height is compromised, there is metabolic acidosis and urinary pH is high. So somebody said you have acidic urine, acidic blood, and the urine is not acidic. This seems there is an acidification defect. So do you agree this is distal RTA? So there is acidosis and the urinary pH. So you have to do other tests. Anything else before that? So renal tubular acidosis. So you should always look at glomerular causes also. So in this regards, phosphorus was high. So always creatinine should be measured. Of course, some people do measure, but we have seen cases in which blood gas was done and creatinine was not done, which is a bit unusual, which is not something which is pardonable. It should definitely have been done. Now we know that this is RTA. The question is it type 1, type 2, proximal or distal RTA? Type 4 RTA is very simple. You will be having hyperkalemic variant. Acidosis is not severe. They will have mostly polyuria, failure to thrive. You will be able to identify them easily. Main aim is to distinguish between proximal and distal. So urine pH is a good test. Anybody who has acidosis should have an acidic urine. If your urine pH is more than 5.3, this goes more in favor of a distal RTA. Now, infection can cause some confusion, especially if you have a urease producing bacteria, you will have more production of ammonia and you will have an alkaline urine as we saw in the first case. So whenever you're using urinary pH, you have to look at two things. Urine routine microscopy to exclude UTI and a urinary sodium to exclude dehydration. If somebody is dehydrated and if somebody has a urine infection, your levels of urine pH will not be reliable in that regard. So dehydration, again low urinary sodium, your acidification may be defective because sodium is required from that perspective. So before you really look into urine pH, look into urine RM and urine sodium. Only if they are fine, then you should go ahead with urinary pH. Fractionation of bicarbonate should be measured only when you have a reasonable amount of bicarb. If your bicarb is 13 or 14, your Fe bicarb will be low and you will say this doesn't fit like proximal, this looks like a distal RTA. But you should ideally do it once your bicarb is around 20 or above. And then of course you use the fractional excision of bicarbonate, which is basically urinary bicarb upon serum bicarbonate into plasma creatinine upon serum urinary creatinine into 100. So this is how you will measure in that regards to distinguish proximal and distal. So levels are usually less than 10% in distal and more than 10% in proximal. Other measure which is considered to be a very gold standard measure to differentiate proximal to distal RTA is the urine to blood CO2 difference. Now, urine to blood CO2 difference is a marker of distal acidification. If the difference is less, it means there is a problem in acidification. If the difference is good, you are really acidifying well in that regard. This should always be done when you have metabolic acidosis. Because when there is no metabolic acidosis, why would somebody want to acidify the urine? So the parameter to look at is urine and blood CO2. The role is that if the level is low, this is distal RTA. If it's high, it's proximal RTA in that regards. Now, based upon these things, we can classify into different forms of RTA. So bicarbonate, typically, if it's very severely affected, this is more likely to be distal. Mildest is type 4 and proximal is slightly in between. Potassium is pretty much low, but if it's very severely low, I'll think this more like a distal RTA. While on treatment, if it becomes low, it's proximal RTA. If it's high, of course, we are talking about type 4 RTA or a very, very rare form of hyperkalemic distal RTA. Urinary pH should be below 5.3. If it's above 5.3 in acidosis, you're dealing with either distal or rarely type 4 RTA. Urinary calcium is usually high in distal, but a high urinary calcium does not exclude proximal RTA. We have discussed that proximal RTA also has hypercalciuria. Why do you have hypercalciuria in RTA? So, the major cause of hypercalciuria, hypermagnesiuria and everything is because of your sodium. So because of that gradient, that's you have a problem. So potassium is being lost, all the positive ions will be lost. This is part of the RTA picture. So Fe bicarb, as I said, will be high in the setting of proximal RTA as compared to the other forms, and ammonium production will be low, especially in the distal RTA. So metabolic acidosis, look at anion gap. If it's high, think of diabetic ketoacidosis, organic acidemia, lactic acidosis. If it's normal, look at urinary anion gap. If urinary anion gap is negative, which means that ammonium production is normal, this is GI loss. If urinary anion gap is positive, which means it's a renal tubular problem, it is RTA. Look at potassium. High potassium means type 4 RTA. And then to distinguish between proximal and distal, urine pH is a good measure to look at, and Fe bicarb also can be assessed. Now, when you're measuring urine pH, what precaution will you take in taking that urinary sample? So you can put a drop of oil and then you collect the urine. So oil, because of surface tension will be, or the density will be on the higher side, and then you can easily assess from that perspective. So then you can classify them into a proximal versus a distal RTA in that regards. So 3-year-old boy with failure to thrive and hypokalemia, there is metabolic acidosis, bicarbonate is low. What you're seeing here is anion gap is normal and urinary anion gap is positive. So what are you thinking, Dhwani, here? So we have to do a creatinine. Also, although hypokalemia makes it a bit very less likely to have a primary glomerular disorder. So in that scenario, urinary pH was 7.5. So this goes more in favor of a distal RTA, and Fe bicarbonate was high. So what do you think here? So this is what we discussed as the first case, that you have to think of urine RM. So before you look into urine pH, look at urine sodium, look at urine RM to decide whether you really have a urine pH which is reliable. This case we already discussed, 12-year-old girl with multiple fractures, failure to thrive. Again, a case of distal RTA with diagnostic confusion in that you had amino acid urea. So why is there amino acid urea in distal RTA? So secondary hyperparathyroidism can cause glucoseuria, amino acid urea, Fanconi syndrome like picture. But the key message is look at the case. The first case was a young child who had presented very early. That's more like a proximal RTA. This is a later severe presentation, more like a distal RTA. Fractures I have generally seen is in the setting is mainly with distal RTA or very, very young children, then it's proximal RTA. So this becomes important. 4-year-old boy with rickets, calcium is 8.2, potassium is 3.8, phosphorus is normal, ALP is high. So this is a case of rickets. Base excess showed mild metabolic acidosis. He has not been given a lot of vitamin D till now. But because somebody thought that this could be RTA, they did a pH which showed metabolic acidosis mild and a normal anion gap. And then they labeled the child as distal RTA based upon a urinary pH which was 5.6. So do you think this is distal RTA? Hmm. Why is ALP normal in RTA?
It's the turnover is less, the bone turnover.
Yes, so ALP is a marker of bone formation. So when you talk about other causes of rickets, you have got more formation, more resorption. In RTA, everything becomes less. So that is one sign. What else?
So if we see low calcium, so it could be due to vitamin D deficiency, and long-standing vitamin D deficiency causes secondary hyperparathyroidism, and that can cause mild acidosis as well as the Fanconi.
Yeah. So the level of acidosis that we are seeing here is also not very significant. Now, many times I have seen people say, okay, let's do a ammonium chloride loading test to see whether this could be RTA as a covert, incomplete distal RTA. This is a concept which comes largely from adult studies. Now, that's predominantly for patients who have renal calcification. To my experience, I have not seen a patient who comes to me with distal RTA particularly with fractures and bone disease without a severe metabolic acidosis. So what I'm trying to say that people say, okay, you may have a compensated RTA and still rickets. That's not the case in children. So if you have a pH and bicarbonate level of which is mildly problematic, I don't say that this is contributing to RTA. This is the effect of RTA. This is the effect of rickets rather than the cause of rickets. So to speak, this is secondary hyperparathyroidism, and vitamin D should be done in this case, which was very, very significantly deficient. Now, once we know the type, we can then go about evaluation. So we've discussed in detail about various drugs. So drugs like anti-cancer drugs, antifungal drugs, then many of these antipsychotics along with anti-epileptic drugs can cause this scenario. Always look for eyes, and we have a couple of patients who have problems which in terms of cystinosis and other disorders which can cause the same scenario. Hearing abnormality is very, very common, and this is what Dhwani had talked about, distal RTA. So always ask for that. The genetic form may often have hearing abnormality. And liver disease, there was one girl with hypothyroidism and distal RTA. I think she had the same sort of a picture. And hepatomegaly, very common, would be in the setting of glycogen storage disease, fructose intolerance, and Wilson's disease, which you have to be worried about. Further workup for distal RTA should include an ultrasound for nephrocalcinosis and an autoimmune panel. Sjogren syndrome we have seen quite often. SLE has already been reported. Proximal RTA, you have to rule out genetic causes. So generally, we would now recommend a panel to look for genetic causes of proximal RTA. You can find problems in the GLUT transporter. You can find problems in the cystinosis as well as other tyrosinemia genes as well. Type 4 RTA, you have to work up like a hyponatremia, hyperkalemia. So that's that salt wasting group which you want to evaluate. Now, management, of course, for distal RTA, mainly you have to give bicarbonate. The initial requirement of bicarbonate may be high because you have deficit for a long time. So you may require 6 to 10 millimoles per kg per day to begin with. Subsequent requirement becomes less. Once you give bicarbonate, your acidosis becomes better, your potassium excretion becomes better, your potassium may become normal. So as we were discussing, you will have hypokalemia at diagnosis, which improves with treatment in that setting. So options are sodium potassium citrate, or now we often use just sodium bicarbonate in the form of tablets as well as liquid suspension, which is available. So sodium bicarbonate is something which is quite good from that regards. You aim to maintain bicarbonate in the normal range because low bicarbonate will cause bone defects to continue. You want to initiate at a high dose and maintain around 1 to 2 millimole per kg per day. Preparation citrate, or as I said, bicarbonate is preferred. Citrate may be helpful because that may help in preventing calcification as well in that regards. Ultimately, citrate is converted into bicarbonate. If there is persistent hypercalciuria, we need to avoid salt intake. So often these patients will have a lot of salt, so that you have to avoid, and thiazide diuretics can be added. And you can then prefer a potassium salt also in that regards. Monitor urinary calcium, do an alveolar ultrasound and renal functions in that regards. You expect improvement in height, in bone. Hypercalciuria will improve if you give sodium salt. Increase if you give sodium salt. So you have to be careful, and you can think of potassium, as I said, in that scenario. So this becomes relevant from that regards. For treatment of proximal RTA, you have to be giving more amount of bicarbonate, but more bicarbonate you give, you will be losing that bicarbonate. It is something like treating hypophosphatemic rickets. If you give more phosphorus, you will lose more phosphorus. So it's very difficult to maintain a good amount of bicarbonate. So as I discussed earlier, proximal RTA is a milder form, more difficult to treat. Distal RTA is a severe form, more easy to treat. So here you would need a very high dose of bicarbonate. And once you give bicarbonate, as we discussed, if you have a sodium load, you will have an exchange there and you will develop hypokalemia. So here hypokalemia will worsen during treatment. So you have to be worried about. You expect improvement in growth. You need to give phosphorus as well because they also lose a lot of phosphorus. So you have to give them phosphorus in the form of an inorganic phosphate, and polyuria will improve. Potassium may worsen. So you start at around 10 to 15 millimoles per kg per day. Sometimes adding a thiazide and an amiloride may help in this regards. It reduces your bicarbonate requirement. Potassium, you have to start. While in distal RTA, often you may give potassium to begin with, and then you can be able to take it off. And phosphorus supplement, as I said, at a high dose is required from that regards. There is a risk of hypokalemia, and you may need to give vitamin D, and the condition improves over time. You have to monitor after a week, maintain bicarbonate level more than 22, and then monitor 3 monthly. Type 4 RTA, the cause has to be treated. So if you have hypoaldosteronism, give them aldosterone. If it's pseudohypoaldosteronism, you give them soda bicarbonate, fludrocortisone, more sodium, soda bicarbonate, and then voltage defect, you have to give more sodium in that regards. Often it may be a self-limiting acidosis. Hyperkalemia is a major issue, and you have to monitor for growth. So before we go on to the ASCII, we'll see if there are a couple of questions which are there. So Dr. Ibrahim is asking, how will a proximal RTA result in low ammonia production? Acidification of urine normal in proximal RTA. Therefore, the ammonia in urine should be high in both diarrhea and proximal RTA. So this is often a confusing scenario, but it has effectively been noted that actually overall ammonium production is defective in proximal RTA, and therefore you have a urinary anion gap which is positive. Dr. Bifina is asking, would urine pH and urine calcium become normal after starting treatment with distal RTA? Yes, so hypercalciuria does tend to improve, but if it is persisting, in that scenario, you should ideally be giving more amount of thiazide and restricting salt in that setting. And calcium supplementation, you can give at a reasonable amount of calcium and vitamin D, which is required in that setting. So we'll now move forward towards the OSCE scenario. So there will be questions which will be coming up. So can somebody have a look at the answers and who is giving the answer? 30 seconds is more than, we'll give 15, 20. So anybody who answers that questions. So maybe Alapan and Dhwani, you can just open the link. So we'll start off with the OSCE, and over to you, Vibha.
Thank you, sir. I think now everybody knows everything. So these questions are very easy for everyone. Let's begin with the first question. So we have this 2-year test was done, which was acidic, and the anion gap was 12. So is this case a case of RTA, or what should be the next step to be done in this case?
You can write on the chat option.
Any answers?
So there are some answers coming in the Q&A.
Q&A, one can see. RTA, it's not RTA. What should be the next test? It's RTA is not the diagnosis. So what should be done?
Considering RTA, what
but next step.
You have acidosis which is there, and a normal anion gap. So you should exclude causes of acidosis and other causes
Other
of
causes.
anion gap. Any answers?
Creatinine, definitely it's the correct answer. We should go for the serum creatinine and rule out the glomerular cause of the acidosis. Bifenum. Okay. So this was TKD and it was falsely diagnosed as RTA. Now coming to the second question, we have this 3-year-old boy who came to us with failure to thrive, diarrhea and acidotic breathing. When the blood gas was done, it was acidic in nature. And sodium was 131, potassium was low, and chloride was 110. So what should be the next step to be done in this case?
You have hypokalemia with metabolic
Acidosis.
So any answers? I think we have very few differentials of hypokalemia and
Acidosis.
One, of course, is RTA, and we're discussing on RTA. The other ones are.
That's the next steps of what should be done.
So, what are the other differentials?
Sir, before this is hypokalemia with the metabolic acidosis, first we have to see what is the anion gap here. So definitely, I think nobody has given the answer. So it's the anion gap. So after anion gap is normal, now the differentials are very limited with the
Urinary anion gap.
Yeah. Yeah, definitely the next step was to get the urinary anion gap, and which was 5. So most likely diagnosis in this case would be?
You have a urinary anion gap which is -5 or +5?
-5.
Minus. So what do you think? Anybody is answering?
So I think nobody has. Yeah, definitely it's the GI loss, bicarbonate loss is diarrhea. Now coming to the next question, we have this 5-year-old child with rickets. As you can see, there is a genovulgum with widening of wrist here, and the blood gas shows there is the acidosis is present, and the urine pH is 5.8, and the anion gap is normal. So this patient was labeled as distal RTA and was sent to us. So what is the next step to be done in this case? I think we have already discussed it.
RTA, that is a big question. There is definitely a lot of rickets which is there.
And then sir, definition. She presented with short stature.
She was short as well. So before you label RTA, what would you think of? Anybody has answered?
And this question has already been discussed here.
So before you label somebody as
RTA.
the key question here is that
what is the vitamin D ALP? What is the vitamin D level?
And the metabolic acidosis is mild.
Mild.
So
Yes, sir.
it's unlikely to be RTA. So renal dysfunction, we have to rule out, of course, a vitamin D deficiency and secondary hyperparathyroidism.
So this was the case of vitamin D deficiency with secondary hyperparathyroidism. Okay. So coming to next question, we have this 6-year-old boy who presented with polyuria and polydipsia, and they came with their ultrasound which showed nephrocalcinosis, as you can see in the picture, and the creatinine level was normal. He has low sodium, which was 125, hypokalemia, and the calcium was 8.8. So what should be the next step to be done in this case? Is it RTA or something else, or what should be done here?
Nephrocalcinosis with polyuria, you don't have any bony abnormality.
No, sir. Just the patient came with a X-ray and.
So one important thing that if you have low calcium and you have nephrocalcinosis, what does it mean? Serum calcium is low.
Serum calcium is low.
But you have nephrocalcinosis.
It means the calcium is being excreted in the urine and lungs.
It means on one hand, if you have high calcium in the blood, high in the urine, which means this hypercalcemia. This means the cause of hypocalcemia is urinary loss.
Yes.
So you are losing in the urine, which becomes.
So definitely this is tubulopathy, but yeah, definitely.
So who did blood gas?
Yeah, blood gas should be done because tubulopathy, it could be RTA or it could be another cause. So if the blood gas shows it was alkaline and the bicarbonate was 26, so what could be the most likely diagnosis in this case? Any answers? Yeah, definitely it is the Bartter syndrome. Bifenamide. Okay. So we have a next case. We have a 3-year-old boy who presented with failure to thrive and polyuria and polydipsia. There was a acidosis and urine pH was 7.5 and there was a hypokalemia as well. He was diagnosed as a distal RTA and patient. This was yeah. This question is also.
So clearly you have a child whom you label as RTA. Urine pH should be looked into only when you have a normal urine microscopy and the urinary sodium is normal. If you have dehydration and if you have a
UTI, yeah.
Honestly, a diagnosis in terms of the urine pH. That's an important question.
So coming to the next question, this is a numerical question. We have this 8-year-old boy who presented with some blood reports where the sodium was 135, potassium was 3.2, and chloride were 114. Blood gas shows of the pH 7.1, bicarbonate 12, and base X is -18, and urine sodium of 40. This urine potassium of 4 and chloride of 42. So now you have to calculate what is the anion gap in this case. Blood. Definitely, it's the anion gap is 9. Sodium minus chloride plus bicarbonate is the formula. The next question is, what is the urinary anion gap in this situation?
Yeah.
It's a
2.
yes.
Somebody asked it.
Just negative.
Negative. Okay, it's not. It's positive.
Generally, it will be much more positive. So it's not a very confusing picture. If it's actually a GI loss, it will be significant. -20, something like that. So this is classically a case of heart.
And this is the just general question of pediatrics. Calculate the expected PCO2 level in this case. We know the formula and
what should be the CO2? What is the ratio of bicarbonate and CO2 in terms of compensatory response? Other one. Yes.
1.8 plus minus 2. So
in this case, you expect it to be 26.
It's 26. Okay. So the last case, we have this 10-year-old male child who presented with jaundice, growth failure, and abdominal pain. Definitely low cellular plasminogen, and the 24-hour urinary copper challenge was more than 500 after the penicillamine challenge. And he was diagnosed as the Wilson disease. Okay. Now the mother complains he has a frequent bedwetting. So what is the cause of polyuria in this case? I think it's very clear here.
You've already discussed that you have Wilson disease, tyrosinemia, cystinosis. Which form of RTA do they cause? Generally proximal. Any answers?
Any answers? No, no one has given the answer. Definitely, it's the proximal RTA due to the Wilson's disease. We have this 17-year-old female who presented with weakness of all 4 limbs. There was a history of episode of periodic paralysis, but there was no history of any drug or polyuria. And on the asking further, she has given us that she has a complaint of dry and she is using this artificial tears very frequent. She has a dry mouth since 2 years.
So we should ask the diagnosis. Somebody who presents you with periodic paralysis and dry mouth. I think diagnosis is very clear. So of course we're talking about RTA.
Yeah, definitely this is a distal RTA. Yeah, but what is the cause of this distal RTA? Jogger? Yeah, definitely it's jogger, it's not SLE, sorry. And what treatment would you give in this condition? No, sir, definitely just a treatment of distal RTA. That's bicarbonate, the potassium citrate. So this is a rapid fire. This is a one-liner one, and you have to respond very quickly here. What protects the renal calcification in proximal RTA?
Why do patients with proximal RTA?
Citrate, okay. Bifenamab has an citraturia, definitely citraturia. Now, the hypokalemia worsens with bicarbonate treatment in distal RTA or the proximal. This is the simplest question, I think. Proximal RTA, definitely, it's the proximal RTA. Next question, for the proximal RTA, what are the two better tests than the urinary pH?
To diagnose proximal RTA,
Yeah.
which test you will prefer more?
Who has answered? Bifenamab is again fractional excretion of bicarbonate only after the correction of acidosis and the urinary to blood CO2 difference of more than 20 mg. Next question, name two medications that induce distal renal tubular acidosis. Distal. Yes, sir. Distal. It's the proximal. Yeah, amphotericin B in the FS point. The last question, urinary anion cap is a marker of. That is discussed it many times here.
Surrogate marker of production of what? Somebody asked.
Renal ammonium production. Okay, that's all. Thank you.
Thanks a lot, Vibha, for making this very interesting quiz. So, we have tried to cover a lot of RTA in this regards, and all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information, resources, look at the books and the portal, along with the courses which are there, which are available in that regards. We'll see if there are any particular questions which are there, and then we will go forward from there. So I think there were a lot of Q&A answers, but there are no specific questions. So we will now close this session, and we will hope to join again with more sessions